All right, so I am really excited to introduce our next speaker, Dr. Rene Zamora. Dr. Zamora completed his undergraduate in biology at the University of Sydney, as well as the University of Oregon in Eugene, Oregon. He is a graduate of Washington University School of Medicine in St. Louis, Missouri, and he completed his residency at Barnes Hospital in St. Louis, Missouri. After his residency, he completed a fellowship in medical surgical glaucoma, as well as oculoplastic surgery, eczema refractive surgery at O'Donnell Eye Institute. So another really interesting thing when I was looking at Dr. Zamora's biography was that he is fluent in Spanish, German, Tagalog, and Italian. Isn't that amazing? I thought that was like the coolest thing out of like his whole bio. I thought that was amazing. And so I talked to him last night. We were at the speaker's dinner and I asked him, well, how did you get involved in Italian? And he said, well, you kind of took me a while. You know, I was there and, you know, just trying to learn. It took me like 3 months or, you know, kind of a long time. I'm thinking, oh my God, 3 months. I mean, it would have taken me like 30 years. So another great thing, Dr. Zamora, he's a wonderful surgeon here. He's a wonderful MD here in Vegas. And I've actually known him since I was an intern. When I did my internship here, he was a speaker for a lot of different things. He's very knowledgeable on a variety of subjects. So very excited to have him here today, local doctor. So let's give him a warm welcome.
You advance it.
This way.
Thank you.
Mm-hmm.
Oh boy, I don't know if I can live up to what Wu University just told you guys. So thank you again for spending time from your families and free time on a Sunday, I guess Sunday afternoon now, right? And for all those people online, thank you very much for, again, spending part of your Sunday morning and afternoon with Wu University. Appreciate the invitation. And hopefully, who wants to hear about UPNIC? Yeah, I think we'll talk about UPNIC and oxymetazoline for about 45 minutes, and hopefully I can answer most of your challenging questions about ptosis and acquired ptosis in regards to its relevance to your practice, in your practices, in town, out of town, in Europe. So, molto grazie. Buongiorno or buonasera. What else? Guten Abend. Willkommen. Okay, in Spanish, buenas tardes. Bienvenidos. Okay. Gracias. Okay. So acquired blepharoptosis is the main topic essentially for our CE credit. This it's really a clinical diagnosis, ptosis. It's basically patients are going to come in your clinic with a chief complaint of what? My eyes are drooping, right? Have you ever heard of that? I think we need to keep in mind that a lot of patients, when they do their morning routine, right, they look in the mirror and they say, what's happening, right? And it's hard to live up to Dr. Blumenstein's one-liner, but essentially when you look in the mirror, oh my goodness, is that the way I look? And it could be unilateral and bilateral, but most importantly, it could be congenital or acquired, right? So I think we should note some of the differences between acquired ptosis or droopy eyelid, and the definition is an abnormally lying upper eyelid, and it could be non-functional or functional. And the difference between non-functional is cosmetic, and functional meaning is starting to affect what? Our superior visual field, right? And even though the patient may come in complaining about a droopy eyelid, they don't, by show of hands, how many people think that the patients would notice their superior visual field starting to be affected, right? I mean, think about that. At the end of the day, that becomes more functional because they can't do their everyday things that they need, including driving, including, even reading and things that they want to do. It could be very helpful to offer them all the modern treatments, whether it's medical or surgical, to help them with their everyday lives. And at the end of the day, we're all here to help our patients, right? And I think it will be a great benefit to you. So MRD, we keep mentioning this MRD term. I think Dr. Barnett already mentioned a little bit of. So MRD is a mean reflex distance on primary gaze. So it's the distance of your corneal light reflex. So now, a lot of people don't pay attention to the corneal light reflex. Certainly, before my fellowship in oculoplastic surgery, I didn't pay attention to it. Why would I, right? We go straight to the cataract, to the retina, right? That sort of thing. But again, let's retract a little bit and move backwards, right? Let's take a look at the adnexa, right? We tend to kind of neglect that in our exam. And what I want you to do is just stand back for a moment, think about oxymetazoline, what it can do for your patient, and take a look at the eyelid, the eyebrow, the excess skin, right? I want you to spend, how long does it take to do that? Folks, 30 seconds. What's 30 seconds out of your 10-minute exam? And what it will bring to your practice is so much more. Your ROI for that 30 seconds, believe me, is a lot more. And we'll go over that at the end, all right? So the normal mean reflex distance is 4 or greater. So it says here in this slide deck. Just remember that. Normal is 4, abnormal is less. Very basic. Take a look at the cornea. You have those, what do you call those near cards, right? In your office? Anyone don't have a near card? Now, don't use the near card. What I want you to do is look at the edge and you have a ruler there. Did everyone know? You have a ruler, right? And take the ruler, measure your corneal light reflex to the upper eyelid margin. Voila, MRD/1, right? That's it. And I just want to make sure, I want to make this as interactive. I mean, if there's something that, I don't want to mention anything over the top about anatomy. It's not necessary for this lecture, but I'm just going to mention what's relevant to oxymetazoline and what in your practices as being clinically relevant, right? So you can interrupt me if you want to, because I'm here anyway, we're live. And for those virtual ones, you know, I don't want overwhelming chat questions, but we have all day, folks. We already had our champagne, so. And the point I'm trying to make here, I think essentially it becomes when you have a non-functional between 3 and 4 MRD1, it can progress eventually to a functional issue, right? So a mild, moderate, or severe ptosis of the eyelid, okay? I just want one of the take-home messages of my talk this afternoon. So we talked about congenital and acquired. I think those are very important to distinguish between the two. And the reason being is congenital is usually an early onset type of ptosis. That's point number 1. And point number 2, it's usually a myogenic issue. There's something wrong with the muscle inherently, whether it's genetic, however you want to call it, familiar history of congenital ptosis. And why is that key? If there's something wrong with the muscle, inherent, right? Would something that acts on the muscle itself work? Yes or no? No. I wouldn't consider your primary candidate for oxymetazoline is somebody with congenital ptosis. In fact, I would avoid it because congenital ptosis, the treatment of choice is what? Surgery. It's a frontalis sling. That's what it is. Just going to mention that procedure. You don't need to remember that, but it's a surgical issue. It's not a medical issue. Let's jump to acquired ptosis, right? So acquired ptosis, it could be trauma. It could be a disinsertion of the levator muscle. We'll talk about the levator, a little bit of the anatomy and the muralis muscle. I think of the upper eyelid as a kind of a unit. And the two muscles that are involved in an anatomical raising of the eyelid is called the levator, aponeurotic muscle, and the muralis muscle. Just two muscles out there that insert on the top of the tarsal plate and lifts the eyelid, right? Very easy to remember. And what happens is sometimes over time, either trauma or just weakening of the insertion of that muscle into their insertion point to the tarsal plate and the superior tarsal plate can cause a ptosis. And that's what you're looking for. That's what you're looking for in relation to oxymetazoline. Hope that's clear. All right. And I don't want to, I mean, we talk about excess skin, that's mechanical sometimes. But, you know, this is an astounding statistic that I found. I mean, remember Dr. Blumenstein mentioned there's a percentage of people with dry eye. There's also a percentage in your practices. How many percent of your patients have lid ptosis? Think about that. Here in this study, 12%. I bet you it's more, right? Have you guys heard of the one-liner? If you don't look for it, you don't find it. Look for it and you'll find it, right? Again, I'm going back and backwards and saying, let's not neglect the adnexal exam, right? The lid, the brow, the excess skin. That's sort of my kind of, it's like his message, inflammation, dry eye. Me is adnexa exam. It's something you need to incorporate in your physical exam in these patients if you're considering adding this in the clinical setting, right? And what are the other risks? You guys know surgery is a risk factor. That's fairly straightforward. You see a lot more contact lens patients than I do, right? That's a risk factor. Contact lens wear, which particular contact lens is a big risk factor for the disinsertion of the muscle from the tarsal plate. You know, think about that. That can happen over time with chronic use, whatever contact lens your patients are using, that can disinsert from the posterior side. Remember, there's a posterior when you blink, right? That can actually literally disinsert the tarsal plate from your muscles. And it's something that you need to think about. And our underlying disease can do it too. All right, so, but the 12% or more, I think of it as opportunity, right? It's opportunity, and I like that term. Now, the other thing, Dr. Barnett this morning, if you guys didn't fall asleep, or I certainly didn't, she had a great lecture. But you got to aware ptosis, acquired ptosis could either be, like I said, a disinsertion of the muscles from the levator or from the tarsal plate versus a neurologic. Now, I'm not going to belabor the point here, but you need to be aware of the neurologic causes of ptosis. And we've listed 4 here, right? Obviously Horner syndrome. If there's a cranial nerve palsy, that's neurogenic, that's obvious. And maybe myasthenia, if you can diagnose myasthenia without, those are rare, and obviously are very rare as CPEO, chronic progressive external ophthalmoplegia. But those are not common. Just be aware they exist. And we are all trained to know and identify which one's which, right? So obviously if it's a syndrome presenting in your office with diplopia, right? Ptosis, you have to think about what? Neurogenic, a neurogenic etiology with diplopia, ptosis. Most especially, I just want to point out, and a lot of practitioners miss Horner syndrome. So Horner syndrome and ocular motor palsy could be lethal, right? So those are important to immediately send the patient to either a neurologist, and if a neurologist is not available, to the nearest emergency room, basically, because those are urgent and could be life-threatening. Just want to mention that as a cause of neurogenic. And you can really, if you read the textbook, you can really tell apart, because the one thing about Horner's and CN3, right? Don't ignore the pupil. The pupil is key, right? The pupil here is your friend, right? It's your friend, all right? And we all know that. So what do I do on exam? On physical exam, how do I assess acquired blepharoptosis? We already talked about MRD1-1. Folks, guys, what's a normal MRD-1? 4 or above, right? Write that down. Write that down in your binder, okay? Visual field, we already touched upon that, right? Superior, that's pretty much the difference between functional and non-functional. That's pretty obvious, right? So the one thing I always do on any acquired ptosis exam is levator function. Anyone aware of levator function? Okay, so what we do with levator on primary gaze, what you do is you hold your finger on the eyebrow, right? And you have the patient look on primary gaze, you have the patient look down and up. And what do you do next when they start doing that? Take your near card, right? Take your near card. What's on the side of that near card, folks? A ruler. A ruler. And the normal, again, this is another number I want you to take down. A normal levator function in an adult, any adult, is between 8 to 10 millimeters. That's a key portion of the exam. And why do I say that? Because if the levator function is poor or non-existent, is that acquired ptosis, folks? No. That could be congenital or something else, a muscular dystrophy, right? It could be a myogenic issue. And are those good candidates for oxymetazoline? The answer is no. So be very cautious about prescribing something when the levator function is non-existent or poor. And I'll repeat it one last time, and I want to inundate your lunch, right? Interrupt your lunch. What's the normal levator function? 8 to 10 millimeters. So 4 to 5 millimeters for MRD1, levator function 8 to 10 millimeters. Remember that if you're doing a complete adnexal exam. And that's my pet peeve for today. So what are the treatment options? You all know this. I mean, yeah, eye drops. I think Dr. Barnett really hit the nail on the head with this. We have an eye drop now, right? Since last year. We'll talk more about that. I'll give you the data. And the only con is what? It's really compliance. I mean, but you know, we treat glaucoma patients, we treat dry eye. These patients are probably already on what? Eye drops, right? So very minimal con for the eye drop. Well, surgery. So there are significant absolute and relative contraindications for surgery, right? Not everyone is a candidate for surgery. I'll give you a classic example. A lot of our Part B patients are on what? That would be probably a relative contraindication for any kind of lid surgery. Blood thinners, right? Somebody with significant cardiovascular disease and abnormal heart rhythm are almost, I mean, I guarantee you the cardiologist is going to put them on either generic warfarin or some oral Plavix or something like that. And you know, those are something that's iffy if the patient really wants to push a surgical maneuver. And the reason being is our eyelids and our eyebrows are what? Very, very vascular, right? And the last thing you want is do a procedure and the patient's waiting in the PAR or the recovery room. And what happens, right? If they are in blood thinners, you can get a retrobulbar hematoma, and that's an ocular emergency, right? Because it can compress the optic nerve, and you get a permanent optic neuropathy, right? That's an emergency. We tend not to do that because we don't want to, you know, that significant complication is there. And I'm saying it because it's not even just people on chronic blood thinners, even somebody taking what, a baby aspirin here and there, it could be significant. So think about that. That's the big con, bleeding. And, you know, infection, I mean, that's rare, but it's more on the bleeding issue. Well, off-label medication, I mean, aproclonidine, iopidine, heard of those drops, right? So, you know, there are unwanted side effects. What's the main unwanted side effect of aproclonidine and iopidine? Even generic brimonidine, right? Is significant follicular conjunctivitis, right? The allergy rate for those is close to 20–30%. And what if you didn't do a gonioscopy? I'm a glaucoma specialist too. What if you so happens you didn't do a gonioscopy on somebody you wanted to put on brimonidine generic or aproclonidine? Can it exacerbate angle closure? Yes or no? Absolutely. Because you see that? Pupillary, it could be an inadvertent pupillary dilation. So what exacerbates angle closure is the mid-dilated pupil on a patient with a narrow angle. Be very cautious. And so, meaning at the end of the day, if I document something, I tend to do a gonio. If you're not comfortable with somebody, I'm going to put on oxymetazoline just to document that, you can see the angle, right? Just in case you miss a narrow angle, right? So it's always for your own information. I'm not saying, but just medical legally, I think doing a gonioscopy prior to putting somebody in oxymetazoline will help. Something I want you to write down, all right? Do a gonio. Non-surgical, mechanical, what, taping the lid? Does that work? All right. The scleral contact lenses work, Selena? Yeah, they do. But the patient has to be compliant, right? So another issue, the con is the compliance issue. They may cause discomfort and may be temporary, right? So you want something more permanency and less temporary than this. So oxymetazoline, who hasn't heard about this? I'm sure you guys heard about it, and all those online have heard about it. I think that it's very helpful. I have my own one-liner at the end. I want to push it out upon you guys and see what you think. But so I'm going to read this verbatim. This is not a promotional program. This is a CE. But it was a brand name. Upneek oxymetazoline 0.1% is indicated for the treatment of acquired blepharoptosis, which hopefully we've defined. We know how to examine and we know how to diagnose, right? In differential from congenital in adults. Okay, this has not been studied in anyone below 13 years old. So don't ask me that question. I'm going to cover it now. And it hasn't been really studied on lactation and pregnant women. All right, just want to make sure I covered that now. Okay, I want to spend a little bit of time on the warning and precautions. Okay, so this may come up in the Q&A. So obviously there's concern about systemic absorption, right? There's always a concern of anything we put in the eye of systemic absorption, right? So when I do my review of systems, I'm contemplating on putting on medical therapy. I always ask about hypertension. I always ask about a history of hypertension. And the reason being is that if you put somebody on oxymetazoline, yes, you'll raise the eyelid, but there is a secondary effect. When they did all these studies, what was that secondary effect? They had secondary whitening, right, of the conjunctiva. And why is that? Why do you have secondary whitening with Lumify? Right? It's a powerful vasoconstrictor, right? Alpha agonist, by definition, is a powerful vasoconstrictor. They not only raise the eyelid in Mueller's muscle because that's an alpha-2 agonist, a powerful alpha-2 agonist, but they also bind to the receptors of your blood vessels and the conjunctiva, and you will get, this wasn't studied, but since this is C, I'm allowed to mention it, you get a secondary whitening of your conjunctiva. Isn't that great? Not only are your patients say, doc, right? I look better with my eyelid, right? How come my eyes are white? Remember Dr. Blumenstein, he said the new tan is white, right? Remember that? His one-liner? So anyway, it's hard to beat his thunder. So be asked to review systems of hypertension, really. And if they've had a history of uncontrolled, even though they're on beta blockers or glycosides, it mentions here, I would be very cautious. If you're really pushing this and they've had a history of uncontrolled, 2-3 medications for high blood pressure, essential hypertension, right? Then I would be very cautious. And I mean, some people ask me, do you get clearance from your PCP or a cardiologist? With these rare patients who have had multiple medications of uncontrolled high blood pressure, probably I would. But other than that, if they have routine essential hypertension controlled for many years, I don't get clearance from a cardiologist or a PCP, right? And the second, I mentioned already the angle closure. We all know that. We talked about that. I do a gonio on those patients just to, I'm not saying they're open or closed, but just to make sure I documented in the chart that I did a gonio, the angle's open, right? In defense for your, just in case something happens. And if you see here, those are the things that we've covered. I don't know if you guys see the very last bullet point here, drug interactions, all right? And spending a little bit of time here because there's a lot of your patients. One is hypertension. The other thing I ask is depression. And why do I ask depression? Because the problem with the the most commonly used antidepressants out there are what's called SSRIs, selective serotonin uptake inhibitors. So I make sure I get a history if they're taking antidepressants. And I'm going to go over a couple more here that might sneak up on you guys. The other one, the other powerful antidepressant. So I write that down, SSRI, antidepressants. And the other one is MAOI, monoamine oxidase inhibitor antidepressants. I'll give you examples of them. They may sneak up on you. And I want you to remember these 4 drugs that are FDA approved. Because, and the reason being is, again, I'm really a stickler for safety here. I want to communicate that to you guys, all right? Because we have no control who's writing this or writing that. And it's better for I educate you now, right? And what's going to happen potentially if there's a drug interaction between an alpha agonist and a selective serotonin uptake inhibitor that will increase serotonin levels in your blood, is you can get a lethal antihypertensive, malignant hypertension that put the patient very quickly into the unit. So, and have a hemorrhagic stroke. So that's where it ends up with. I'm stickler for safety. So I'm gonna mention this now, all right? It's in your binder, but I'm gonna take a picture, that's fine. There's 4 FDA-approved antidepressants that are widely used as antidepressants are MA on the class of drugs, MA, monoamine oxidase inhibitors. It's Marplan, Nardil, NSAM, and Parnate. I always put that in my review systems. Are you on any of these medications? And if they check one of the box, right, folks, they do, I would stop, right? This is like, I mean, you're all eye care providers. If they have narrow angles, what do? Stop, right? Because now you're aware of the safety issue that I'm trying to get across. You get the point. So this is not unique to oxymetazoline. This is a class effect. The same thing if you're using a lot of brimonidine for glaucoma generic, this applies. If you're using a lot of, iopidine or aproclonine, this applies, right? So it's a class effect. It's nothing unique to oxymetazoline. Any questions on that? I hope that's clear and it's pretty basic. And so oxymetazoline 0.1%, the brand name is Zondic, we already know that. It's preservative free, so it's unit dosing, okay? It's used once a day to the ptotic eyelid. And this is nice because, like I said, a couple of doctors approached me over at the break, right? And there was an RVL, I don't know if you guys met them. So they can literally go to your office and give you, and then why do I like the samples of the unit dosing? Because you can actually, if you have a candidate patient, they're not on antidepressant, their hypertension is in good control, and they have an open angle, I go, sir or ma'am, you're a good candidate. You're acquired ptosis. What do? Right? I go to my drawer, take my sample, right? And put a drop in. And believe it or not, folks, within 5 to 10 minutes, right? Selena, I mean, 50% of your patients say, doc, I look great, right? So, I mean, why are we here practicing eye care? You want to help your patients. You want to make them feel good, right? This is what all the eyelids about, right? And that's why I use my samples for, just a kind of a one eye. If they have bilateral acquired ptosis, you do a one eye trial and have them within 5 to 10 minutes. And I've seen this. Wow, I see the difference in my mirror. I'm no longer the person I saw this morning, right? Which is amazing. So, and oxymetazoline has been prevalent in a lot of things. I mean, everyone not here of Afrin nasal spray, right? So it's used for allergies. It's over the counter. It has oxymetazoline. And people here in this room, right? They treat dry eye, right? It's in Visine. I don't know if you knew that. They had it's discontinued, I believe, but it was in Visine. You can buy it over the counter. That product, the active ingredient. And reverting back a little bit, because it didn't mention in the safety profile, you really need to wait 15 minutes before a contact lens wear. I just want to mention that. That's another number I want you to write down, 15 minutes before a contact lens. All right, just want to make sure I talked about that before I forget. And but it is prevalent. It's everywhere, right? You can buy it over the counter. And the mechanism of action, I mean, we've already touched upon this. It actually is a big alpha-2 agonist. There's two alpha agonists, alpha-1 and alpha-2. It's more selective for alpha-2 by a 5-fold margin. And the reason that's important is because what's the receptor in Mueller's muscle? Mueller's muscle, if you guys can see that, is the main muscle activity you're trying to lift. It's more concentrated, alpha-2 is more concentrated by a 5-fold margin in the Mueller's muscle, okay? All right, and what's the innervation of Mueller's muscle? I'll buy you an extra dessert if you guys, what is it? Is it cranial nerve 3? Anyone? No, it's not, it's sympathetic. It's a sympathetic innervation. Now, levator, I think, what's the innervation of levator aponeurosis, the main muscle for the ptosis? It's cranial nerve 3, right? And that's how you get ptosis in an acute cranial nerve oculomotor palsy, right? And how do I know that? Because I took a look at the pupil, right? And you got a blown pupil with a ptotic lid. So the innervation of that muscle and the innervation of pupil is the same. It's oculomotor nerve 3, right? So remember that Mueller's muscle, your target, and the neuromuscular junction is sympathetic. And that's what I'm trying to communicate here. We're going to go, and this is really the last portion of the talk, is the clinical trials. I'm really excited. So any one question about the diagnosis? I talked the safety profile and what your target. I think I made it pretty clear cut. There's nothing, should be nothing confusing here. How you diagnose acquired ptosis and in your everyday clinic. You're going to say on Monday when I open my office, well, Dr. Zamora had me write a few things, but I'll tell you, you can put it in your flashcard. I'm not going to tell you to write anything more. That's it. Fairly simple, except for my mnemonic, my acronym at the very end, because I want to, compete with Dr. Blumenstein. So they did the trial mainly is for 2 weeks, right? The trial put oblique vehicle versus oblique oxymetazoline versus vehicle, right? For 2 weeks, and they did a safety trial that extended it to 6 weeks. And the key thing I want to mention here, they've measured vital signs, right? Vital signs, blood pressure, respiratory rate, and pulse. Pre-installation in every visit and post-installation. I'll tell you right now, there was no effect. Pre and post-installation of oxymetazoline, before I forget to say that. There was no effect on vital signs. But that doesn't mean you won't ask history of hypertension or uncontrolled medication. You should, right? Even though in the clinical trials, they had no effect on the vital signs in this particular case, and they had more than 350 patients in the trial. And that's how they did the study. What are the endpoints? I think it's important to mention. Superior visual field, the Lancaster superior visual field test is an endpoint to make your Basically, they asked the patient, how much can you identify in the visual field superiorly once you instill an oblique? That's one of the endpoints. And can you guys guess what the second endpoint is? I've talked about it only 10 times. I mean, you talk about something 10 a million times, it becomes true, right? So yeah, so MRD1 is the other endpoint, right? So pretty basic. And so how do they divide the population? Pretty much, the only thing is about 75% were female versus male. I don't know if anyone pointed it out in the studies, but that's what the breakdown was. And there was over 98% compliance. I mean, you gotta remember in clinical trials, you're paying these patients to be in your plane to use your drop. So if I get paid, I'm gonna be there, boss. So those are the, as far as race, a majority were Caucasian, but there were some African-American and Asian patients and some Hispanic patients as well that were included in the study. So let's talk about LPFT, superior visual field, is for just the acronym for that. And this is the data on day one, upon installation of oxymetazoline in the patient. You already get a statistical, that's to me is very compelling. And that's why I use my sample here. You got a sample in your office, pick your drawer, put it in the patient, because you have data to say that in this particular phase 3 trial, you already get statistical separation highly on day one. And obviously you get it in day 14, but in general, that's in day 14, that's how they figured what's the peak onset of action. It's usually around 2 hours. You get the peak lifting of the eyelid around 2 hours after installation, but you can 50% of patients, you can get it in 5 to 10 minutes. As somebody who have experience with this can attest, right? So that's the data on superior visual field, highly statistically significant in day 1 and 2 weeks. MRD1, same thing. Day 1, highly statistically significant result. This has happened even after 6 hours. That's how you figure out the duration of action. And at 2 weeks, after 2 hours, the peak onset of action, you get a highly statistical significant difference between MRD1 vehicle and the treatment group. Okay, and that's how it got approved last year when they submitted to the FDA. Very compelling, both superior visual field for the functional patients and the actual lifting of the Mueller's muscle in these patients. Right. Nothing to write down, folks. So part of the issues when we're making the diagnosis, I want to make sure that there are several acquired ptosises that we see in the clinic. One of them is brow ptosis. And folks, if you see the arrow here, everyone see the arrow? I drew it up there. That's the eyebrow. That's not the eyelid, folks. That's the eyebrow. So please do not confuse the anatomical brow with the eyelid. And remember, when we measure, remember I told you folks, measure levator function. Why do I tell you to hold the brow with your finger? Because the brow actually lifts the lid a little bit. So you want to get an accurate measure of just the eyelid itself for the levator function. Don't forget that. Place your finger on the brow and hold it. And then have the patient do a down gaze and up gaze and get your ruler and measure it for the levator function, please. And what's the treatment for brow ptosis? Surgery, right? It's not an eye drop. Eye drop's not going to fix a brow ptosis. You need either a coronal brow lift or an endoscopic brow lift. That's what they need, if that's what they're complaining about. See this patient? Everyone in the back, see this patient? So let me ask you guys a question. Is the MRD1 normal or abnormal in this patient? It's normal. It's completely normal. So why did the patient come in the office? Something is drooping when I look in the mirror this morning. And what is drooping is the eyebrow. Everyone get that? So this is pre-op, that's post-op surgery, right? So she had an endoscopic brow lift. So like this. Folks, like this. It's not this, it's this, right? So please identify that before you start anyone on oxymetazoline. The second confusing misconception. I mean, this, I don't need to explain this. Look at the picture. Picture says 1,000 words, folks. So what's wrong with this patient? So this is excess skin on the eyelid. What is the MRD1 for this patient? It's normal. It's a normal eyelid position. So meaning greater than 4 or 5. But what's happening is you have excess skin on the upper lid. So what happened between left and right? What happened there? Surgery, right? What was the procedure? It was an upper lid blepharoplasty. They need a blepharoplasty. As a matter of fact, and the reason I mentioned this case is because what if I prescribe oxymetazoline in the picture on the left? What will happen? It can actually exacerbate and make it worse. This is the last thing you want to do to this patient. If they have excess skin with a normal MRD, you don't want to put them on oxymetazoline because your wow factor is going to become, doc, it's a callback, right? Doc, I look in the mirror when I went home, it looked worse, you know? Well, it was never a problem. So you're fixing a non-problem in this case, all right? Any questions on brow? And I mean, just want to make sure you're aware of these two conditions that can confuse the issue. So please identify excess skin and brow ptosis before you even try to prescribe anything else. Again, it's handsome young man, right? What was the issue? What was his MRD1? It's normal, completely normal. What was the problem? Dermatochalasis, right? What's the difference between left and right, folks? Surgery, blepharoplasty. So again, be cautious about prescribing to the person on the left. Just make sure everyone gets that, kind of home that. Now, this is a real patient, before and after. Question, does this patient have dermatochalasis? Yes or no? No. The patient doesn't have an excess lid skin. Does this patient have brow ptosis? No. There you go, bang. You've got an acquired eyelid ptosis in this patient. What do I do? I take a look at the agnesa, make sure they have open amidogonio, whatever. Ask the history of hypertension, blah, 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 and antidepressant. Then, wow, before and after, right? 2 hours later, look what she looks. She goes home, doc. You know, did you have a magic wand? Same thing. Another case. Does this patient have dermatochalasis? No. All right. So you can see I'm driving home a message here. You know, I want you to hone in on what you're looking for. You're trying to look for something, you're going to find it, but make sure you're focused. All right. You understand and identify what you're trying to treat. Before and after 6 hours, take a look. Looks like a different man. Again, normal MRD on the left, on the right, but abnormal MRD. So his MRD1 in the left here is around 2 or 3. Does everyone see that? Then 2 hours later with oxymetazoline, look at the gentleman. Happy as can be. Wow, right? So I'm just saying the wow factor is just no longer premium IOL or refractive surgery. You can actually have a wow factor in your clinic. Don't you agree, Selena? I mean, this is absolutely a slam dunk for these kinds of patients. And what did you do for that patient? You identified accurately in your diagnosis what they had. You're actually targeting your treatment regimen for acquired blepharoptosis. So that's my take-home message for this talk. Busy slide, but in the clinical trials, I just want to let you know there were about 350 patients. 9 patients actually discontinued, even though they were getting paid. So 9 out of 357 is less than 2%. That's a great. I mean, most drops, you can talk about, cyclosporin or lifitegrast, dry eye stuff. I mean, most in the clinical trials, most of those discontinuation rates just from simple burning and sting are in the double digits, but this one is less than 2% in the 40, in the 42 days or 6-week trial in the safety, very little discontinued. And I want to mention there are no deaths, right? 0 deaths. And, can this cause punctate care, dry eye? It's probably, this is very common, installation and site pain. Maybe if you want to be proactive, this can happen in less than 2% of the patients. If you want to be proactive about this, if you're going to think about it, but in any eye drop that we use in clinic, this can happen, right? Even higher percentages with those dry eye medications if you're very well experienced, and very safe medications. But the point being is, going back to the last slide, the discontinuation rate was less than 2% in the actual clinical trials. And that what impacts me and resonates to me, because remember, these are very, very compliant patients. As far as on a 0 to 4-point scale, as far as eye drop comfort, very comfortable. I mean, over 99% of the patients said didn't have a problem as far as ocular discomfort is concerned, and instilling the drops once a day. All right, just want to point that out to the live folks and the online folks. This is my summary slide, okay? So we're now down to the very end here. So it met both the primary and secondary endpoints as far as visual field and MRD1. We all know that. The clinical studies all had a very low discontinuation rate, very acceptable safety and tolerance profile, which we like in our clinics. Finally, we're on the finish line, folks. So what's my what does DES mean with Dr. Blumenstein's lecture? It's not dry eye syndrome, right? For me, I have a different meaning for DES. It's not dry eye syndrome. For me, it's diversity in your practice, enhancement of your practice, and satisfaction in your practice. Why do I say diversity in your practice? You can offer your patients walking in the door something else, right? Which we, prior to approval, we had nothing, right? Enhancement. What do you mean by enhancement? You're actually enhancing your practice. And if you have an oculoplastic friend or good oculoplastic friends, if you actually tell them you're about to refer them for ptosis repair, right, or blepharoplasty or combine, and you give them a prescription for oxymetazoline, you can actually simulate what's going to come up post-op. And don't you think that's it's a powerful tool to me? And that's how you enhance. And what's the S? Satisfaction, right? Remember the gentleman, 5 to 10 minutes, you put the drop in? Wow. Need I say more? Need I say more? Questions? Any questions from the live audience, if I may? I know you had a lot of questions in the beginning, so.
Yes, so thank you so much, Dr. Zamora. That was a wonderful presentation.